Mary Zeil, who is the Director of Clinical Consulting, and Scott Pettigrew, who is an IT consultant for the Tri-State Regional Extension Center at Healthbridge. Their biographical sketches are extensive, so I am actually going to have them provide a little background on themselves and then also kind of paint the picture as it relates to the organizational structure as well. So I think that you will enjoy this session very much, and without further ado, let's welcome them.
So I'm Mary Zeil, and we're from Healthbridge and under the Tri-State Regional Extension Center. I'm a nurse, and we will introduce ourselves and our organizations as we go. Scott's going to go first, but he's definitely IT, definitely privacy and security, definitely an expert. Love having him on our team. I'm clinical, he's IT. We still get along. So
it's a little bit of I say tomato, she says tomato, but we get along.
yeah,
just fine.
so it is really a good multifunctional team. So with that, Scott will introduce himself and we'll get started.
Hit the slide. Spacebar. Maybe, yep, there we go. So my name is Scott Pettigrew. I am the senior practice consultant at Healthbridge. I'm with the Tri-State Regional Extension Center. Can everyone hear me okay? All right, I don't want to eat the microphone, so I have 13 years of healthcare IT experience. Started off in 2001 with a company called PocketScript, and PocketScript was one of the national e-prescribers in the United States. Installed e-prescribing systems in about 13 states, and personally installed about 400 different organizations, ranging from a one-doc office to Mass Eye and Ear Institute. We installed their e-prescribing solution back in 2003. After I left Zix Corp and PocketScript, I spent 3 years as a systems analyst at Cincinnati Children's Hospital and supported just a ton of IT systems throughout the hospital, clinical as well as some of the more financial. Including the interfaces that tied all those together. As a matter of fact, most of the time that I got calls in the middle of the night, it was for those systems, for those interfaces, not necessarily for the systems. And I've spent the last 3 years at the Regional Extension Center helping doctors select, implement, and correctly utilize their electronic medical record systems so that they can attain meaningful use.
Okay, and again, I'm a nurse. I've had 30 years experience in the clinical area, cardiac intensive care, surgical intensive care, telemetry, occupational health, urgent care, med-surg. I ran an outpatient primary care office for 20 years in a rural area east of Cincinnati. My husband's a physician, and we were very interested and committed to changing the healthcare of the region, and that was our goal starting out, to help do what we could to change the epidemiology of the region. In our practice, we had 4 providers. I implemented an EHR in 2001, and we were part of a CINA data extraction pilot for our registry. We were part of the Primary Care Innovation Group for the Robert Wood Johnson Foundation, which was a lot of process and outcome measurements. We were a leading practice in that out of the Cincinnati region. We were part of the health measures and Bridges to Excellence public reporting pilots, where we were level 3 on both of those. And we were the 3rd out of 40 practices in the whole Cincinnati region. And we were part of the primary patient-centered medical home health collaborative cohort 1 for the PCMH rollouts in the state of Ohio. We were level 3 on there. So a lot of our improvements included between the blood pressure, hemoglobin A1C, microalbumin, aspirin, eye exams, all the diabetic measurements. Basically, our average of each of those indicators was 92%. So our diabetics in our population, between the various indicators, we had very, very high success on those measures. And it was a neat thing because it really involved not only what Scott does as far as IT processes, but how to redesign a primary care office and get good results. As far as, so we work for Healthbridge. It's a health information exchange. It's a nonprofit, and so it's been in existence for a long, long time. We work with 4 other HIEs, Dayton, CCHIE, HealthLink, Northeast Kentucky Rio, and Quality Health Network in Western Colorado. We're connected to a lot of health departments, over 40 hospital information exchanges. We connect with 27 different ambulatory EHRs, and we deliver up to 6 million messages a month, 60 million messages for last year. So it's really, really well-connected community as far as the HIE, very, very well-connected as far as health transformation. So that's just a quick picture of the Tri-State Regional Extension Center, and I think you're all pretty much familiar with what the RECs do. They were 62 RECs funded across the country to help physicians implement EHRs and to help enter the data in a meaningful way. And so what we do as a HIE is to go in and help analyze workflow, help them dissect quotes for their EHR implementation and the cost, and help them to see which meaningful use program that they can apply through. And to really, for me on the clinical side, and I can say this for our whole team, they're all very, very committed to have on-site with these practices to help make meaningful use meaningful. And again, part of a lot of the meaningful use is in the privacy and security, which is what Scott does. So, for me, I've been on the clinical side a long, long time. And so if you're not familiar with the triple aim through the Institute of Healthcare Improvement, it's really everything doctors want to do. And so it's really redesigning the system of care to allow doctors and their staff to do what they were trained to do. So it's really, really neat that we can see that happening in Cincinnati. So we have, in Cincinnati, we have the CPC, the Comprehensive Primary Care Initiative, where providers are being paid per member per month to improve the quality of care, implementing registries, attaining meaningful use, already using their EHRs, taking like care stratification, decision support tools, and really getting together as a team and redesigning the care. We were a beacon community where we really improved on the quality initiatives. One of the main, and I can't go into all the details of every project at HealthBridge, but one of the main components of that, for instance, we were talking about data the other day. In Cincinnati, it used to be before Beacon that pediatric asthma kids on average were in the emergency room every 6 months. Now that average is every 9.5 months. So taking the data, using it in a meaningful way, makes very significant improvements, and getting a collaborative team to work toward those improvements have been our goal, and it's really, really happening in Cincinnati. Also patient-centered medical home, and we have the Medicaid health homes. And like I said, in the first PCMH cohort in Cincinnati that we were a part of, we were actually paid through the major insurance companies a per member per month fee. So for 2 years, we were paid extra money to do good care. So, and really, I think the payment system, using the data-driven, is going to change the payment system. So after 2 years of the PCMH cohort, the insurance companies came to us and said, your data is so good, we're going to pay you an additional year. So that's really unheard of, that insurance companies come to us to give us more money. I saw one of the medical directors at one of these insurance companies a couple months ago, and he came up to me and he said, your data is so good, tell your husband, my husband's a physician, tell your husband to call us, we want to pay him more money. So that never happens in insurance, it never happens in healthcare, but yet it can happen, and it's happening in Cincinnati. And then obviously the health information exchange and the interoperability, and I'm not a BI analytics expert, Scott's the IT person, but it's the whole comprehensive way to take the data in, measure the data, take cost and clinical information, and have valid results that physicians can see and act upon.
Sounded pretty good.
Yeah. So I don't like to talk IT in front of an IT person, so here I am. Okay, so, and I won't go into the details of the meaningful use goals, but these are the national policies. Some of those coincide with PCMH, and there's about 35 different measures of the patient-centered medical home that coincide with the goals. And really, if you sit down and analyze it, this is everything physicians want to do. They want to improve the quality, they want to engage the patients, care coordination, population health, privacy and security. So it's really changing the dynamics of a primary care practice to help deliver care. Now, we're going to talk about point and counterpoint. The main thing for me, as far as coming from where I came, coming into HealthBridge, is, there's going to be a shortage of physicians. It's $170,000. Physicians come out of medical school. They have $170,000 from medical school. 85% of them come out with debt. There's a huge amount of expectation that we're going to need a lot of physicians in the years coming up, and a third of the physicians at 55 and older are planning to retire. We have baby boomers. We're going to have more insurance coverage. So my big emphasis is we need to keep good physicians in medicine, and trying to take our meaningful use process and make it meaningful is kind of what our goal has been in the Tri-State REC. So we're going to hit upon the simplicity of meaningful use, privacy and security, CPOE, and clinical quality measures as far as meaningful use objectives. Scott's going to present the meaningful use, and I'm going to talk about the counterpoint, which is, I think meaningful use is great. I think measuring data is great, but the big problem is you have to get in there in the weeds and see what the workflow is, because there's repercussions of doing it incorrectly or doing it in an IT way that doesn't involve in clinical. There's repercussions doing it in a clinical way that doesn't involve IT.
So part of what we do at the REC is actually going to do those process analyses and make sure that we're able to actually fit meaningful use in. So I'm going to talk about the simplicity of meaningful use, and I instead of putting quotes around simplicity, because how many have actually done meaningful use at your organization or are working towards meaningful use? How many of you think it's simple? Good. So let's talk about the simplicity of meaningful use, because really this is what IT vendors try to sell. This is what the government's trying to sell, and this is really, in most cases, not the case. 25 measures, of which 20 total must be achieved. And those measures all fall within the 5 elements that we showed on the earlier slide. Of those 20 total elements, 15 must be achieved from core measures, and there may be cases where you have exemptions from measures. And then from the menu set measure, of which there are 10, you must achieve 5. And these are all ranging in goals, but all falling underneath those 5 main policy goals. However, of those 5 menu set measures that you achieve, one of them must be from 2 public health measures. And if you've done meaningful use, you know all this. This shouldn't be anything new. What is trying to be sold is that most measures center around correct usage of an EHR or basic usage of an EHR, and in stage 1, that really is true. Most of these measures are trying to help physicians input data into the EHR in a way that's searchable, in a way that's reportable, in a way that makes sense, so that you can actually do the data mining, so that you can actually do reporting out of your data to figure out if you're providing good care. And most doctors are providing good care, even if they're not documenting it correctly in the EHR. And the other thing is, most of these items are already expected for providers of Medicaid, Medicare. So there really isn't a lot new for these providers. However, changing the paradigm from the paper-based system that they're used to this new electronic-based system does present some problems. Mary?
Okay, so for Scott, it's simple. I understand it. I think it's great. Scott's memorized probably 1,500 pages of rules, and he likes that as far as meaningful use laws, right, between stage 1 and stage 2. Physicians don't have time for that. They have to focus on taking care of patients. And I'll give you an example. So my husband's a physician. He saw a newborn baby, saw the baby for the first time after the hospitalization, and he picked up a juvenile cataract. So he referred the patient to ophthalmologist, and the ophthalmologist called and said, "That was a great pickup. You did a great job catching that. A lot of people wouldn't have caught that. That baby would have been blind in a couple months." So, for a physician, it takes 15 seconds to diagnose a juvenile cataract. It takes 15 seconds to miss it. So the whole paradigm shift, physicians are doing quality care. They are already doing quality care. They love the work that they do. They want to keep doing it. So incorporating, whether it's meaningful use, PQRS, patient-centered medical home, the CQMs, ACOs, all the public health measures that are beginning to be reported, they already want to do good quality care. So taking a complex issue for them, making it simpler and doing it quick. So it's really 15 seconds. You have 15 seconds to engage the physician to get them in tune to what you're saying. You have to reduce the noise. So when you start with CPOE and you have, you say like core one, it's a CPOE for physicians, and then you add on PCMH, 149 factors, you add on the menu elements, you add on the CQMs, you add on the public reporting, you add on, if you're FQHC, you have other measures you have to do. For a physician, that is a lot of noise, and I understand it. I read it. I love the stuff. I read it on weekends and evenings. It's great. Physicians don't have time to understand. I mean, they have time. They're very competent, very, very smart. If they wanted to commit all of these quality initiatives to a full-time job, they could do that as well. But they have patients to see, and so it has to be done in a simpler way that they can understand and grab a hold of quick and go see patients. And it really has to be designed around a system where you identify what those critical points of failure are. So in a primary care practice, critical points of failure like the transitions in care or missing a diagnosis or not getting the medication reconciliation, and developing that process around those systems of care where those points of failure can occur. Now this is obviously, I have a couple graphs in here that are going to be hard to read and you're not going to be able to read them, and I understand that. But I went through and I analyzed, if you look at what a physician has to do in a course of a day, and you take the levels of complexity that the physicians have, you go over the number of medications that they have, the potential of tests to order, the potential referrals to make, the potential changes in medication, changes in plans, interpreting the test, and you analyze it over the course of that day. It ends up they have 2 critical decision points every minute. And that's what I want to illustrate in there. So when you're going into a physician's office and say, here's the simplicity of meaningful use, and then we're going to do PCMH, they're already having 2 critical decisions, and any one of those could be a critical point of failure, and that's what they're focused on. And this, again, is going to be hard to read, but this kind of is an example of, if you take the physician office when back in 1990, and you had, according to where you were, you had 40% overhead, 42%, 45%. In the last 20 years, the overhead in primary care has escalated exponentially. So now, according to where you are, some places are 55%, 56, 58, 60%. When the insurance curve goes up, you know, it's higher. But so you look at how a physician practice medicine in a fee-for-service, discounted fee-for-service, or where patients don't pay, and you look at what they're doing now versus what they were doing 20 years ago, you can kind of picture why an older physician may have some resistance in change, implementing an EHR and doing a lot of the quality initiatives. The physicians aren't in it for money. I've known physicians for 30 years. They love medicine. They want to take care of patients. But if you look at the business side, and we've talked over the last couple of days about the business side of healthcare. We all know it's a business. Physicians generally don't like that part of it, but they're forced to act within that business side of healthcare. But if you look at the percent of overhead 20 years ago versus now, physicians have to see an additional 50% more patients for the same revenue. And so you're going into a system, they're seeing more fee-for-service patients, more difficulty covering the overhead. You're a hospital system. The hospitals are saying we can't, the doctors are saying we need more staff. Hospitals are saying we can't give you more staff. We're already maxed out on our overhead. And then we're piling a lot of meaningful use, PCMH, and all the other quality initiatives. So to me, it's very important to understand that. So when you go in to physicians who are resistant, physicians who maybe, we don't want physicians to retire. We want physicians to stay in medicine. So creating tools around making those complex issues simpler really goes a long way with physicians. And this is just a screen as well. And some of the costs that has escalated is around the insurance industry trying to control costs, which I believe in the insurance industry too. I think we have to control costs. When the gross domestic product for healthcare is over 18%, we have to have a fiscal sustainable process. But you have about $83,000 per physician per year in this country who we spend in every office for pre-search, prior auths, billing, checking on claims, and this was out of the health affairs last fall. So it's an escalation of that overhead, and now physicians are trying to turn patients in a fee-for-service system that fights against quality. So the real solution for me, and as we've been in our practices, is really trying to get rid of the noise. And I know, on a big system-wide level, and I can tell from a lot of the people that have the different speeches, a lot of really good things happening, and really getting, and one of the big points I heard was getting the whole team engaged as far as helping them to lead, getting in the clinical, the lab, to help them lead the projects. That's really, really awesome, and really, I was really happy to hear that. So as far as designing tools to determine what the priorities and tasks are, always identify the physician task as opposed to tasks that others can do, and being respectful of their roles, responsibilities, and time constraints, highlighting the simplest path and removing unnecessary complexity. And I know, just like with Scott and I, he's IT, I'm clinical, we see both different sides of the quarter. So, but yet we communicate very effectively because we've made that our goal. So from what we've done in practices, and we have over 1,800 physicians, 55 of our providers have attested to meaningful use, and if you include the adopt, implement, and upgrade for meaningful use, we have 70%. Which that was our goal for last year. So we got 70.05% of our providers who have either attested to meaningful use or have adopt, implemented, and upgrade. And I think, and Scott can speak to this as well, but I think for us, one of the, and it sounds somewhat simple, but one of the ways that we've done that is creating simple one-sheet tools that are colorful, take all the pertinent factors, put it in an order that makes sense, that a doctor can take and acclimate that in 15 seconds.
So let me speak to this tool real quick, because this is a tool that we boiled down from a Medicaid guide put out by the State of Ohio Department of Job and Family Services. That was a 30-page guide on how to attest and register for meaningful use in the state of Ohio for the Medicaid incentive. That's great, but most office managers and almost none of the physicians that I know have time to sit down and read a 30-page document. However, when we set down this one-page document in front of them that on the left-hand side outlines the institutional memory items that they will need to gather and keep, and really kind of boil it down to a highlighted best path. And you still have the 30-page guide to go back to should you need to do some reference. But this is really the summary that was not included by the state of Ohio. And the reception that we've gotten from all of our physicians and all of our offices on this alone has just been absolutely amazing. So this is kind of the idea of boil it down to really highlight that best path, provide a visual tool instead of more of a conceptual tool.
And really for the Tri-State REC, we're one of the leading RECs in the nation for Medicaid registration, AIU payments, and meaningful use. And I really think a lot of it has boiled, because they keep saying, what's your plan? How did you do it? And it's very simple. So I think you take complex things, you make it into a simple process, and this has helped us be the leading REC in the nation, and it's been very simple. This is, and of course you can't see this as well, but I just wanted you to see the picture of what we did. So, for me coming in and seeing all the meaningful use measures, I read them again, And it didn't make sense to me how they were being presented to us by ONC. So I took all of the meaningful use measures and I put it in a clinical workflow, and we made posters of this. So I color-coded it by physician, RN, receptionist, and office manager so that each person knew their role. We made posters, the practices would use it up on the wall. It's not a project plan. Offices don't do project plans, unless you're owned by the hospital and you have project managers, but that's not a typical thing that practices know a lot about, project planning. But this made meaningful use very visual and visible in a tangible way, so that the doctor didn't have to worry about everything. The doctor only had to do the things in the blue. Each person had their role and responsibility, and then it was easy for the person running the reports to post the percentages on each measure. So on one sheet of paper, it was a summary that they could use throughout their meaningful use reporting period.
Yeah, and when I sit down with my providers, I go over this, and unfortunately, they still, this is about half of the actual entire poster, and the feedback I always get is, what, I still have to do 8 of them? I've cut your workload in half from what you thought before, and they're still saying I have to do 8. So.
Well, and it goes through in the way a physician thinks. It
really does.
Yeah, so they don't have to do everything today. They don't have to do everything tomorrow. Just do the first thing, then just do the second thing. So it's very logical clinical workflow from a practice point of view, and practices really loved it. And of course, there's more to the poster I couldn't put on here, and then we also did the menu elements as well. And Scott will address privacy and security.
One of the biggest things I do working with practices is help them with a single measure of meaningful use, and that is the privacy and security core 15 objective, which is to protect health information created or maintained by the certified EHR technology through the implementation of appropriate technical capabilities. Well, that's great. And they say that you have to conduct a review of security risk analysis per a specific section of the compiled Federal Register, and implement security updates as necessary. And the doctors their eyes get about this big, saying, what do we have to do? And so we've really boiled this down to about a 10-step process, which is still, in my opinion, far too long. But it does actually boil down to a set of understandable steps. And I've created a lot of tools around this. Some of them I've taken part in boot camps that ONC and CMS have held with the regional extension centers, helping them work through privacy and security. So first of all, the HIPAA and HITECH Acts require this for all providers, not just the providers going through meaningful use. So if you are in an organization that has not, that utilizes technology that stores, processes, or transmits electronic health information, then you have to be doing this already. And if you're not, you need to really look at that. So I usually get a lot of panicked looks when I say that. Failure to comply with this may subject providers to sanctions by ONC and the Office of Civil Rights. And this is really about protection of patients' rights to privacy and security. It's really about that confidentiality that I know is important to all healthcare providers to maintain that. But at the same time, you have to get your work done. You have to be able to provide that care and do so in a way that you may need some collaboration. So back to that 10-step process. We have a number of tools, some of them provided by ONC, and of course, when you get tools provided by the governing body, it's going to be more complex, and this is a 30-page, very comprehensive Excel document that the doctors really don't understand the language for, so I have to sit down and help them with it, and the office managers don't understand it either. And that's why they're coming to us, of course. But what I'm boiling down to for them is really a common sense step by step by step. Here's what we're doing. Here are the checklists that you need. Checklists like we have to know what employees have as far as technology in their possession. So we want to say, okay, what is your inventory? Just take an inventory of who has what. So that if something gets lost, we know what it is. Are things being encrypted? If so, we have to be able to prove it. Do you have policies surrounding the use of this technology? If so, we have to prove that you have it, so we have to collect that and know where it is. But we also need to review that on a yearly basis. And there's about 8 different checklists that I came up with to help these office managers and these providers really get a grip on the types of things that they need to start keeping track of. And in most cases, it's a checklist. It's just a log. So it's a one-line entry when you do a policy review. So that you do the policy review, you keep the old policy, and anything you change, then you keep a new copy of it so that you can prove that you're actually going through these processes. Are you doing disaster planning? What happens if the worst happens? What happens if in Ohio, in Cincinnati area, about 2009, we had a hurricane roll through the area, or the remnants of a hurricane, and in some cases it knocked out power to offices for a week and a half. Well, 10 days, if you're without power on an EMR, that can be a very disastrous situation for you. So talking with the doctors about how do you handle that type of situation. So that's the type of things that I put around privacy and security.
This, in my opinion, is how a lot of doctors see privacy and security. Doctors are very, very committed to patient confidentiality. I don't know of any group that is more committed to that. As far as meaningful use, the processes that they have to do are very clinically oriented. Once they get through what that picture is going to look like, they can get through that. I see privacy and security as the biggest gap. Even, and Scott's an excellent privacy and security expert, but even in practices who have attested to meaningful use, I've gone in, I've seen practices tape their logins to a physician tapes his login to their computer because he may forget it. I walked in a practice, if I wanted to, I could have picked up the old paper charts that were sitting on the front desk. I could have picked them up and walked out. So I think as far as that is, you can do your reporting, you can measure those percentages by the computer, but I think the hands-on continued diligence in the privacy and security is very, very important because it's such a scope of work that is outside the normal realm of a primary care office.
So one of my favorite things to do around privacy, so let's go to the next slide. So I kind of covered a lot of this. I step in as kind of an outside SME subject matter expert and sit down with the practice and walk through, for example. One of my favorite things to do is to walk through sometime around lunchtime, and invariably there'll be a cell phone or a smartphone laying on a counter somewhere. Pick it up and pocket it, and at the end of it say, here you go, this just walked off on you. And how do you prove what's on it and what's not on it? Really get some eyes opened. And I would never do anything with it, but my job is to open their eyes and to make them understand it, and they know that. Going through the risk assessment questionnaires, the fact and guidance sheets. Who's done a privacy and security audit at their organization? Who's overseen that process? How was that process? How big is your organization? And how long did it take you to accomplish that?
A year and a half.
And you have to update that yearly?
Yes.
Do you see, I mean, this is the problem, right? So it took her a year and a half to do this, and already by the time the 12-month period is rolling around, she's expected to be rolling around and redoing this and doing a review and an update. Now, of course, the second time around, it's not quite as bad as it, but you still have to gather all these things in place and really kind of understand the process in order to do that. On to my next point. There are at least three objectives surrounding prescription and CPOE workflow. And of course, if you CPOE, electronic prescriptions, prescribing, or lab ordering, these are very huge workflows within the practice. So it makes sense that the government really wants to make sure that the EHR process encompasses this and does so in a way that makes sense. So you have to have 30% of your patients with at least one medication ordered through CPOE that you've seen during your reporting period. You have to have enabled drug, and drug allergy checks throughout the entire reporting period. How do you prove that, by the way? Because the government has not put into place a requirement for an audit, for audit trails within the EHR. A lot of them have it, but we're relying in a lot of cases on screenshots taken at the beginning and end, and maybe at spot checks throughout the reporting period, but there really isn't a good way to prove it. And the auditors have started asking some very tough questions about that for practices that have come under audit. By the way, one of the things I think about all the time when I'm working with practices is how do I help this practice survive audit should it happen? And so I'm really helping them document. It's really about that for the practices. And finally, to generate and transmit 40% of permissible prescriptions via certified EHR technology. This is one that always comes back to bite the doctors. The complaint on this is always that there's too many clicks, it takes too long, it doesn't make sense. So what I'm trying to do is work with the doctors, work with the practice to really help them understand and utilize best practices. So for example, if you have the capability to take down the patient's pharmacy that they'd like to go pick up at today at check-in rather than the point of care, that's less clicks for the doctor. Making sure that historical prescriptions are in there so that the doctor, instead of doing a prescription entry, is doing mostly refills and updates. Those are things that really speed up that process. Making sure that order sets are in place is also critical. Another three here, I'm not going to cover these, but again, very important workflows throughout the practice. The whole point of this is to build safety controls and efficient methodologies around these huge practice workflows to make sure that we catch errors, to catch critical events, but also to use the power of that EHR technology to make things easier as well as to do that, but also to provide a way for doctors to help patients lower their out-of-pocket expenses, to keep them on formulary. Now, of course, that doesn't just lower the patient's out-of-pocket costs, it also lowers the payer's cost, but which, to be sure, is a driving force behind it. When I was at PocketScript, most of our clients were actually payers trying to lower their costs, not necessarily the patient's cost. That's one of the benefits, of course, is it rolls downhill, but we were seeing significant cost reductions for the payers.
And my counterpoint on the CPOE, I think CPOE is great. I think with the 7,000 deaths related to medical errors, with up to 100,000 deaths related to, or 7,000 related to prescription errors, 100,000 related to complete medical errors in their entirety. I'm a complete advocate of CPOE. What I've seen in practices that implement CPOE is, unless you get down and analyze the process and the workflow, I see physicians staying in the evenings doing electronic refill requests. I see patients not getting in for their routine appointments because now the scripts are coming directly from the pharmacy. So getting down in the weeds, analyzing because it still takes time on the staff, because you have patients calling to see if you receive the request, you have patients going to the pharmacy waiting for their scripts, and so that whole acclimation of the process within the primary care practice is essential. And I've heard complaints from physicians, I'm staying late doing refills. So you have to analyze that whole workflow process of setting the appointments before the patient leaves, and because when a physician pulls up an e-refill request, say if it's with Lasix, he has to check to see if the potassium's done. He has to check to see, well, are they going to need a prescription refill, potassium called to the pharmacy as well. It's not just a click, it's a thought process. So every one of those e-scripts that are now automatically generated, even they're good, we want our patients to get their medications, it's multiple steps throughout thought processes. So I did this analysis actually for practice to kind of show them the workflow and how much time they were investing into a bad process because the CPOE wasn't acclimated as a process and workflow adjustments in their practice. And it ended up costing that practice over $20,000 a year to do CPOE because they weren't analyzing the cost of their whole workflow situation. And I see that in many practices as well.
Moving on to clinical quality measures, there are actually 6 meaningful use items, 6 out of 25, surrounding clinical quality measures. And these are also ones that I get a lot of pushback from doctors and staff over why does the government care about what we're doing with this? And really what it boils down to are those 5 pillars that we talked about. This is what's helping to reduce disparities in care, measure disparities in care, and helping to provide an environment where we're fostering a continuous quality improvement. So we're looking at things like recording smoking status, and of course this is trying to align with PCMH goals and other quality measure goals. Reporting quality measures to CMS, actually making sure. implementing clinical decision support rules. And the goal here is not necessarily to take decisions away from EPs, but actually to enhance their memory to make sure that they are achieving the goals that they are setting within their practice. So I actually always sit down with my physicians and make sure that the clinical decision support rule that they're choosing is not just one of the generic ones, but actually fosters a goal that they are trying to promote within their practice, whether that's smoking cessation, weight loss, blood pressure, A1C for diabetics, always making sure that clinical decision support fosters that, and it really helps the uptake. Moving on to the next one. Generating at least one report. This is one that takes 5 minutes to do. It's one I do with all of my physicians just to teach them how that they have the ability to pull these reports. All of a sudden lights go off and they say, wow, I could really use this for this project I'm working on. Great, now you know how to do it. Sending reminders, something that is very difficult in most systems, and patient-specific educational resources, which is something I push with all my physicians and is really the hardest one. Seems to me, even though it's a 10% measure, it's really the hardest one to get my physicians to buy into. And I'm still trying to figure out why that is. I think it's because they feel like they're giving that education face-to-face and they shouldn't have to give a handout necessarily, but I'll tell you what, it really makes a difference to be able to go home with those handouts for patient involvement later on.
And that's also a workflow issue as far as if you have standards in your office, this is our standard protocol for taking care of patients, and we're going to assign some other staff resources to help define what are those educational components that a physician needs to hand out to those patients. And it's doesn't have to be physician driven. I mean, in the places I've worked, if a physician tells me something one time, that's golden. You have to, if they need if they need an appointment in 3 months, you don't have to ask them every time. You have notes that document that. If you have a process for diabetics, these are the diabetic educational information. This is how you acclimate it in a practice. This is how you train medical assistants to do microfilament exams. This is how you create CQM posters that align with meaningful use. Because the main thing is, the main complaint from physicians, I feel, from what we've gotten in our community is, okay, I believe in meaningful use. I want the money. I'm already giving good care. I want meaningful use to be meaningful. And that's how we have developed a whole process around it. So when you're doing CQMs, especially getting the clinical team on the front end side of how you're going to change the workflow, how are you, we have posters, magnets, brochures, everything aligned around CQMs. And if you want to engage physicians, make it meaningful from the clinical outcomes, and how is it going to change the practice? Because you can't go in and help a physician do better care, right? You have to remove the barriers so that they can do the care they were trained to do, and to help train the staff at the highest level of their licensure to take work away from the physician. And if you look at Lean Sigma, and you say, when you have a process, there's a constraint, and in Lean Sigma, you're supposed to go in and help that constraint be more efficient. Well, in a primary care office, the physician is the constraint, but the problem is they can't be more efficient. They're already seeing more patients. There's a study, if physicians did every preventative measure, they would have to work 27 hours a day. They can't do more. And so helping other staff within the office take away some of those duties and make meaningful use meaningful within the practice, and make it very visible for the patients. I mean, we had certificates for patients, and we had phlebotomists on site who wasn't one of our employees help doing some of our training. Getting the front desk engaged as far as certain protocols to ask patients before they came in for the visits. Our patients would call and say, I want to get my labs before the visit. Getting all that incorporated into a meaningful way will help drive it with the physicians.
I've covered most of the points on this slide previously, so I'm not going to belabor them. But one thing that the clinical quality measures really helps with is to help measure clinical data at the population level rather than the individual. So the EP has more of a practice-wide view of what he's doing, and it can help to make better decisions based on that. Let's go to your counterpoint.
Okay. And I guess what I would say with our closing is, I love data. I love to be able to measure data. We would run all kind of reports, find out which patients needed their DEXA scans, send them reminders, put reminders on the outer side of the charts through the EHR. We had, in one of our studies that in one of our pilots we were part of, we have this husband and wife, they're both diabetics, really great patients. They brought presents at Christmas time, they brought candy in, they sent flowers on Doctor's Day. They would just drop cards in the mail to us, and they were just awesome patients. And as we were collecting the data, and we were we worked weekends and evenings, just doing good clinical stuff. But when we got our data back, even though we were the leading practice in the primary care innovation group, when we looked at the data in the aggregate for this husband and wife for diabetics, both their hemoglobins A1C was over 8. So data does drive behavior, and it was kind of an aha moment. They're great patients. We do good care for them. We love those patients. But when you see it in the aggregated data, it makes a difference. And then this is a real clinical example, as we were part of some of our measurement studies too. And this is what drives physicians. So for our diabetic population, we pulled a report, and this was for our public reporting. The first year in the ophthalmology report, the report said mild diabetic retinopathy. And because of all the changes, I feel all the changes in workflow regarding national standards for health care. Diabetics all need the same health care regardless of where they are in the country. But this is an actual clinical report. The next year when we reported for health measures, we pulled the same patient's diabetic retinopathy exam, and it said retinopathy much improved. So that's the kind of stuff you need to tie into the clinical quality measures for physicians, and embrace and help them deliver those care that they want to deliver anyway. And then they'll get engaged that way. And so with that, we'll take any questions. I think we have a few minutes.
Do we have time for questions?
Yep, we have time for maybe one or two.
Anything? Yes, sir.
So as meaningful use is implemented, what would be the couple of areas where you have seen inefficient or ineffective work diminish or stop and be replaced by the meaningful use-led activities? Where was the inefficiency and the wastage and or ineffective activity going on?
So one of the practices that I worked with it was 1.5 FTEs that they were devoting just to lab ordering, patient compliance with that ordering, so following up and making sure that those results went into the chart. So one of the goals of meaningful use, obviously, is to bring those in more easily. And they utilized HealthBridge, one of our products, to actually bring in those charts, those lab results into the charts much more easily. They went from a 1.5 FTE job to track those to really somebody doing it for about 10 hours a week, so about a 0.25 FTE. So really, what I have seen is lab and then the around prescriptions and ordering seems to be two of the biggest workflows within the practice that if we can corral with this technology, we really can do a good job of helping practices ease that burden and really help them see the benefits of EHR technology.
And I would say use your data. I think the biggest impact of stage one so far is instead of staff now pulling charts, because obviously not everyone was on an EHR at the beginning of stage one. But instead of those staff pulling the charts, doing paper super bills, repurpose that staff. I mean, we had staff for 10 and 15 years, really great MAs that can be really trained to really be a help to the physicians, and that's an atypical role in a lot of systems where, MAs have more of a minimal role. Repurpose their work. Our staff went from 40 hours a week to 30 hours a week, and they did a better job and did more work, and they got really engaged. I mean, patients knew their names. They would call patients, say, you haven't had, I had one MA, went to an office and didn't fight the patient, but they're like, you will get your microfilament exam on your foot exam. MAs people are in medicine because they love to take care of patients, so reduce the barriers for that. That's the main thing I see in stage one. The main thing in stage two, I think, will be the patient portal.
Patient engagement.
The patient portal. And that's really going to be critical to implement that well, because I could see some inefficiencies remain if that's not done. But it's really getting down and analyzing what the front desk is doing, taking that work away, but giving them other more meaningful work.
Anyone else?
You touched on the challenges for stage 2 and then moving on to stage 3 with the patient portal. 2 quick questions. One, besides the patient portal, what are the other challenges that you see, and how are you preparing the people you're working with to meet stage 2 and stage 3, which both have higher thresholds but more complicated requirements? And the other thing is patient portal. I agree you have to design things better for your office staff and whatnot, but what are the keys to getting the patients to actually use the patient portal? You can design the best patient portal, but still part of the threshold is the patients using it.
So there has to be tangible benefits, obviously, to using the patient portal. You can push all you want, to use something, but if there's no benefit for the patient, they're not going to do it. They're going to go back to the old way. So we need to make sure that the communications are enhanced by the portal, not just providing a different way to do the same old, communication with the same old response times. That's really key to patient engagement. There has to be a tangible benefit for them to do that. As far as moving towards stage 2 and stage 3, I think one of the biggest challenges we're going to see, and this is a little bit of a cop-out answer, and I'll admit to that, but one of the biggest problems that we're going to see is that incentive money goes down for stage 2 and stage 3. And what I think we are seeing and will continue to see is doctors who are going to say, this is not worth my time to continue this. We're going to be spending more money on the portal than we're going to be getting in return on investment via the incentive. And to be honest, the penalties are probably not steep enough to keep that engagement through stage 2 and stage 3. So part of what I'm trying to prepare for is to re-engage these doctors and keep them on the ball with meaningful use.
And I would just say it's the next couple years is going to be a very unique opportunity that it's not going to happen again. But it's really, like as far as when you're running a report and you know now you can run reports, who are the diabetics, who are the patients who are diabetics over 9. Send them that information, because then it becomes a personal response through the portal. And I think that'll help a lot.
And we have time for one final short answer and short question.
Okay.
Thank you. Great presentation.
Thanks.
Is there ROI for physicians when they implement EHR with the bonuses for stage 1? Because it seems very complex, and yet I'm not sure if the bonuses meet the resources that they have to invest in.
I see it as an opportunity that you either do it now where they're willing to give you some money, or according to which system you pick, all the money that you need for an EHR, but you're going to have to, my opinion, you're going to have to go to an EHR now, so you can either get the money now or not get it later. That's how I see it. And the other thing I was going to say is tying the meaningful use into PCMH. So like in Cincinnati, we have insurers that are paying for PCMH. If you're a PCMH level, they're going to pay you more. We also have patients, an insurance company who says to a patient, if you come to a PCMH practice, you don't have to pay your copay. So I think taking the stage 1, stage 2, stage 3, and you really have to get in with, your state organizations, and that's, and if you're not engaged with your RECs, because we're engaged with ONC, we're engaged with the Ohio Health Departments, we're engaged with the state pharmacy boards, the DEA, and all I do every day is try to create solutions for primary care, because we have to take that time and energy it takes to keep physicians in medicine. We need physicians in medicine because we can't control the cost, and we need patients to have good health care.
After working with Mary, that is Mary's short answer, by the way. But one of the things that I want to say about the ROI as far as moving to an EHR, and I will keep this short, is that you really need to look at a 5-year plan, not necessarily a 1-year plan. Because the reality of the situation is it costs the practice money that first year. It costs the practices quite a lot of money that first year. The incentives do not necessarily cover that. Probably easier under Medicaid than under Medicare, especially because they have so heavily front-loaded Medicaid. But I think that they'll start to see that ROI when you do the financial analysis, really start to see that return on investment about year 3 and really see it kick in about year 5.
All right. With that, thank you very much for that great panel.